Welcome to the Interprofessional Education pre-course video, Addressing Substance Use Disorders in Our Practice. My name is Crystal Riccio. I'm Associate Professor here at Roseman University, and I'm also a collaborative pharmacist at the Behavioral Health Group here in Las Vegas, Nevada, that provides comprehensive outpatient opioid and substance use disorder treatment. I will also be joined by Dr. Farzad Kamiar, who's a psychiatrist and addiction specialist at Roseman Medical Group Empowered Program, as well as a clinical assistant professor here at Roseman University College of Medicine. Some questions that we'd like to address with you today is, what is substance use disorder? What is SBIRT and how can I use it? How can opioid use disorder be treated? What is harm reduction and how can it help? And how can I identify an overdose and respond? So to begin with, I'd like to pass the mic over to Dr. Farzad Kamiar, who will be presenting on substance use disorder and a few of the other questions that we'll be addressing today.
Thank you. Okay, so substance use disorder. Guys, this is a big deal, right? When you look at these numbers, they are staggering. In 2021, over 46 million people, over 16% of our population had a substance use disorder, what we call an SUD. And to put this into perspective, comparing this to another chronic disease such as diabetes, diabetes is coming in at 38, 39 million. So we've got more people in this country with a substance use disorder than diabetes. Subsequently, there were a serious number of overdose deaths. When we look at that in 2021, 107,000 drug overdose deaths. And for our reproductive age population, as we see, overdose is the leading cause of death. So we're thinking 15 to 45-year-olds, not cancer, not diabetes or heart attacks or motor vehicle accidents, but overdose. And subsequently, it happens to also be the leading cause of accidental death among adults. So when we think of addiction, substance use disorders, we want to think of these being a chronic disease. So using the chronic disease model and a concept known as parity, which is equality between physical and mental health, I want you all to think of substance use disorders as being on par with another chronic disease, whether it's diabetes or hypertension. And so as such, here's sort of one of the ASAM, which is the American Society of Addiction and Medicine, definitions back from a few years ago, that addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. And so here we'll look at what are some of those components that go into it. So unfortunately, there's no single factor that determines risk. We estimate that somewhere around, 50%, we're calling this plus or minus 40 to 60%, are associated with genetic factors, but unfortunately, that's not the whole picture. So as you can see, big box here, we've got the biology and genes in there, but we've also got the environment, the actual substance that's being used, the brain mechanisms involved, and how they all interplay to unfortunately get us to the state of being addicted or having an addiction or a substance use disorder. A little bit more on that chronic disease model. Like in other things, such as heart disease, which is the bottom two pictures, you can see when we're looking at basically metabolism, right? Rates of metabolism, high being red, low being blue. You have a healthy heart on the bottom left, and it's red because it's contracting. And then you've got a not so healthy heart on the bottom right. And as you can see, there's areas of blue where the contractility has decreased. Lo and behold, when we do imaging studies of brains of those people who are healthy average controls to those who have used substances, you can definitely see differences. So the brain on the top left has got activity, right? And the brain on the top right, it looks like there's a lot more blue and purple, which means that this drug, this substance, has had some effect in regards to just straight looking at metabolism. So we're talking physiological changes. And just adding to that, so here we can see decreased brain function in a methamphetamine user, and this has to do with dopamine transporters. Healthy control on the left, again, high areas, right, of dopamine transport, dopamine activity, etc., and not so much or lower on the right. Here's the cool part, is that there is effective treatment. So much like other chronic diseases, where sort of one of the seminal definitions is that they're not curable, but addiction and substance use disorders, they cannot be cured, but they can be effectively managed, and this is great. We're really fortunate that we have this available to us. And basically, we're looking at a combination of medications when available with behavioral therapy as the most effective sort of modality. But I'll tell you that there's a lot of other options when it comes into substance use treatments, and we'll highlight some of those later. But in general, medications are useful for treating the withdrawal, having folks stay in treatment, and then preventing what we call a return to substance use, aka relapse. All right, so we know that addiction is a chronic disease. We know that a lot of people are suffering from it. How do we figure out who maybe has one and how do we get them plugged into treatment? How do we identify those? And again, sort of this analogy to chronic disease treatment or identification, we have this notion of screening. In the world of mental health, we have this acronym called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. But I'd like for you to think of this as no different than screening, brief intervention, and referral to treatment for diabetes. But things just look a little different in the world of substance use. But SBIRT is a comprehensive integrated public health approach for identification and intervention with patients whose alcohol and/or drug use puts their health at risk. And it has been found, so it's evidence-based, to decrease the frequency and severity of use, emergency department visits and hospital stays, and costs. And overall, what I would like for you to take home is that it's basically decreasing morbidity and mortality across the board. This is an evidence-based practice. So what is screening? Well, it's a process of identifying the possibility of something, some disease, some disorder, right, being there versus maybe not. And for substance use, we're looking to identify patients who might have unhealthy substance use, and if so, then maybe they can use some further assessments, right? If they're open to it, if they're willing, and if they need it. All right. In general, screening should be brief, universal, cost-effective, and have evidentiary support. And this holds true for all types of screening that we recommend. Whether you have an organization such as the United States Preventive Service Task Force or the American College of Obstetricians and Gynecologists, whatever it may be, when they're recommending screening, such as I'm going to look at a hemoglobin A1 screen as a validated method to screen for diabetes. This has evidentiary support. And an A1C, it is fairly brief, it's universal, everyone's doing it, and it is cost effective. So same thing when it comes to screening for substance use disorders. We have to abide by those sort of same principles. But how do we perform screening for substance use? Well, first and most important, well, not most importantly, but very importantly, is that it's universal. So this means every patient. We don't want to use targeted practices because that then gets us into moral and ethical gray grounds, okay? We want to use a standard accepted questionnaire base. So as you see, questionnaire is put in italics because it's not a biologic test, aka, for example, looking at urine, right? A urine test, but it's a question-based tool. And it asks about substances both legal and illegal. And here's just some examples. There's something known as an audit, a DAST, 5Ps, etc. These are all available through major organizations, or if you just Google, substance use screening, these will come up, and then you can see them sort of PDF form, and there's questions. All right, but the practice that we want to make sure that we engage in when we're asking these questions or presenting these to patients is that it's in private. Ideally, no significant others, no parents, no children or anything like that, or friends, relatives that might sway someone's answer, right? And not be not provide an environment where they can be open and honest and might have to sort of hide their substance use. We as practitioners and professionals want to make sure that we're always empathic, compassionate, and non-judgmental. Folks with substance use have experienced lots of judgment in their lives. We don't need to contribute to that. And make sure that this practice, the way that we're engaging in this interaction, is patient-centered. So it really is about the patient. So we talked about the screening, and now the BI part of SBIRT, which is brief intervention. And now this is a collaborative conversation that enhances a patient's motivation to make a change. That's really the gist of it, is that we're trying to enhance the patient's own motivation. I'm not trying to convince them. I'm not trying to force them. I'm just trying to present things in such a way such that the patient can make their own decision to want to institute change. It provides feedback about unhealthy substance use. We focus on education and increasing the patient's own insight and awareness of risk associated with unhealthy substance use. We want to gear it towards whatever steps the patient is willing to make, and we call that sort of meeting the patient where they are. Sometimes this might be just I'm bringing up the topic of conversation, I'm bringing up the topic of substance use, but the patient doesn't want to do anything else, and that is totally fine, right? Versus others that are ready and willing, and they're at that point in their life where they are willing to make a change. Very common example is, get me into rehab. I want to go today. Call them up and tell them I'm on the way, right? All right, and brief intervention uses this principle known as motivational interviewing, which again, the tenet basically of motivational interviewing is to resolve someone's ambiguity, aka enhance their motivation to make that change. Here it is. So what is it, right? It's motivational interviewing, which we oftentimes refer to as MI, a directive client-centered style of interaction aimed at helping people explore and resolve their ambivalence about the substance use and move through the states of change. The principles are using empathy, right? So we want to be accepting, non-judgmental, and try to understand the patient's point of view. That's what empathy is. We want to develop discrepancy. So the patient is seeing something that is maybe different between their current use and the related problems and the way they would like their life to be. So I'm using IV heroin right now. My life is a certain way. And gosh, that doesn't look anything like what I envisioned my life to look like, right? So let's highlight those differences so they can come and see those, right? We want to roll with resistance. This is where hanging in there, right? The ambivalence and resistance to change is absolutely normal, right? And we do not want to argue with patients. We want to meet them where they are. If someone tells you they're not ready to change, they don't find any problems with their substance use, we accept it. We accept it. We don't judge them. We move with it. And in future interactions, ideally, we continue in that conversation. And maybe sometime down the line, we can sort of create that separation between where they are, that discrepancy, and where they want to be. And you want to support self-efficacy. So build confidence that there's something the patient is able to do, and there's by and large, there's usually something that's all that the patient, there's always something the patient can do. And this is chronic disease management, right? And we talked about how there are effective treatments. So realistically, with someone who's suffering from a substance use disorder, there's kind of always something that we can offer, or always something that we can do. So in motivational interviewing, there's 5 specific skills, aka ORS. O, open-ended questions. So not something like, are you feeling bad? Yes or no? No. It'd be like, tell me about how you're feeling, right? Affirmation. So we want to build that rapport. We want to make sure that they know that they're supportive and really have it be a positive experience for them. Reflective listening is big because we have to show them that we're understanding. I hear that you're telling me you're using IV heroin and it's causing all these issues in your life. But I also hear that, you may have suffered some trauma, and so it provides you some of that escape from the trauma. So I get it, right? That reflective listening. Summarize. Important to basically summarize, and then if we can, right, help the patient change direction and move from where they are to where they might want to be. And then elicit change talk, we call it, which is basically having the patient present to us, right? What are these arguments that they are looking at or what that they've come up for to institute change? So here's some examples of open-ended questions. Again, what concerns you about this? Tell me about the not so good things about using. What do you know about this, and what would you like to do about that? Here's some examples of affirmation. Thanks for coming in today. I appreciate that you're willing to talk to me about your substance use. It's hard to talk about, we get it, right? But we really appreciate you keeping on with this. Reflective listening examples. You're surprised that this score shows that you're at risk of problems because remember, it's oftentimes really difficult to divulge that we're even having these issues and we're suffering from an issue. You're feeling uncomfortable talking about this. You'd like to cut down on your substance use at parties, etc., etc. And eliciting change talk. What worries you about your substance? So I'm trying to get from a client, what is their concern about their substance use? What would you like your life to be like in 5 years' time, right? Trying to create that discrepancy of where they are to where they should be, and other examples. There are different approaches, right, to brief intervention. And one is this notion of this brief negotiated interview, BNI. 4 components. 1, you want to understand the patient's views of their use, what's good and maybe not so good. You want to give information feedback. This is the best of your ability, right? Here's what I know about substance use, and here's some of the harms, right? I want to enhance their motivation to change. So tapping into their, this is where I want to be in 5 years. Ah, okay. Well, you're not quite there. What can we do? What can we help you? Do you really want to be there? And giving advice and negotiating a goal, which is, hey, so you've heard the talk. I've heard where you want to be. How can I help? Oh, I can help via this, this, and this. I can give you a referral. We can not do anything right now, but on next follow-up, how about we bring this up again? But sort of negotiating, what does that follow-up look like and what does the future look like? So a little bit more, right? So understand the patient's views of use, trying to develop that discrepancy again. So how do they perceive their substance use and the role it plays in their life? And what are the good and less good or not so good things about substance use, aka the pros and cons? Really traditional strategy. So giving that information and feedback. We talk about asking for permission to give feedback because sometimes patients just don't want to hear it. And a lot of this early on is about building rapport, building trust, and showing the patient that we, one, care, that we're going to be non-judgmental, and that we're really there for them, right? I'm not there to force anything on them. I'm not there to say they have to do this or they have to do that. So as part of that, is it okay if I give you feedback, right? Can I tell you about the results of the screening questionnaire that you did and what that might mean? Right? Can I tell you about the potential impact that marijuana use during pregnancy might have? Those kinds of things. And then asking open-ended questions about the reaction to the feedback to get a sense of, hey, how are they taking this information? So enhancing their motivation to change. Using the 0 to 10 scales is super common, right? To assess their readiness for change and their confidence and ability to change. So what this would look like is, hey, so on a 0 to 10 scale, 0 being absolutely not at all, 10 being I'm ready right now, let's do this. What is your readiness to change? And whatever change looks like for them at that given time. And they'll give you a number. Let's say it's 5. So a follow-up would be, hey, so you said 5, why is it not a 4? Why do you not have less motivation? And they'll give you an answer. And at the same time, why is it not an 8? Why do you not have more motivation, for example? And they'll give you an answer, and then you'll roll with it, right? Same thing for their confidence. So someone might tell you, hey, I'm a 9 in wanting to change, I'm ready to do this, and all these sorts of things. But then when you ask them what their confidence is, they might say it's a 1, right? And you say, a 1, okay, why is it not a 4? And they might say, well, I have a significant other that uses, so it's really difficult for me to also not use when, etc. So give advice and negotiate a goal. Review your concerns, advise abstinence, and kind of universally, that's what we as medical professionals advise, right? To stay away, but realizing that abstinence, which means 0 use of a substance, is actually really not realistic, right? But if we can decrease use, and Dr. Riccio will actually be talking about harm reduction strategies, which is really a lot of it is centered around decreasing use, but also giving referrals is appropriate. And then negotiating that goal or that deal or what the follow-up is going to look like in future appointments. Okay, referral to treatment. This is pretty straightforward, right? This treating substance use disorders is very complex. Oftentimes in primary care settings, it's going to be really difficult to provide that. So we got to get them moving to specialized care. That looks like therapy, behavioral health specialists, addiction medicine, case management, peer recovery support, mutual self-help groups. Oh my gosh, there's so much. And there's also different levels of care from outpatient to intensive outpatient to residential and then hospitalization. And then what types of treatment are there? A little bit on the last slide, but here we go. So there's non-pharmacologic and pharmacologic based. We've got psychosocial supports, we're thinking therapies, peer recovery, which is a specialist who has lived experience, has a substance use disorder, CBT, family counseling, there's abstinence-based 12-step groups, and then there's pharmacologic. In the world of opioids, we have medications, and we talked about how there's medications that have been approved for this, or we will talk about that, sorry. There's agonist medications and antagonist medications that can be used for different scenarios, such as detoxification and maintenance, and then overdose reversal. And what are 3 of those? The 3 that we have that are approved are 1, methadone, which as you see is a full agonist. There's buprenorphine, which is a partial agonist, and then there's naltrexone, which is, and naloxone, which are full antagonists. So they block, right, the opioid receptor. And there's some, you know, opioids effects and safety profiles. Of course, naltrexone and naloxone are zero, nil, nothing, and they reverse overdoses, naloxone specifically. Buprenorphine has a ceiling effect because it's a partial agonist, so it has lower risk of overdose when you compare it to methadone. But methadone is sort of a full agonist, as we call it, much like a regular opioid. And I think that's it. I'm going to hand it over. Oh, sorry, last slide on this. So opioid agonist therapy. It is our most valuable resource when you look at strictly trying to cut morbidity and mortality. This is probably one of the best bang for our bucks, but the huge problem is that the majority of patients are not receiving those medications, so highly underutilized, unfortunately.
All right, so turning it over to harm reduction strategies. Part of what we can do is approach the opioid epidemic or the crisis that we see ourselves in with some of these strategies that I'll go through. And why should it matter to us? Well, approximately 1.7 million Americans have a prescription painkiller opioid use disorder and 526,000 heroin-related opioid use disorders. As Dr. Kamiar mentioned, over 107,000 deaths were witnessed between the time of April 2020 to 2021, and 75,000 of those deaths were related to opioid ingestion, most notably from synthetic fentanyl. So some of the principles of harm reduction is that I'd like to address with you can be met with a lot of ethical questions, right? A lot of people worry about, are they enabling the person that is using substances to continue to use? And so I want to kind of go through some of those principles here to tell you that harm reduction is respect for the individual. Like any medical condition, we want to respect the individual that's presenting before us, that we have a commitment to evidence. And as Dr. Kamiar mentioned, there are specific areas for evidence surrounding expert training and implementation, as well as some of the treatment options that we have available for our population. We want to ensure access to care and services and make sure that those care and services can be received by the individuals as well. And then reducing stigma, which is probably one of the biggest areas that we address with harm reduction, because we know that that's one of the biggest barriers to care and services for our community. Harm reduction is not enabling use or addiction. And when I think about that, one of the things that I counteract that with is a statement that I've kind of practiced on my own, where I'm not enabling the use or the addiction, but I am enabling them to stay alive and as healthy as possible while they're using, in order to potentially get to the point where they want to receive recovery. And as Dr. Kamiar mentioned, it's meeting people where they're at, but it's certainly not leaving them there. It's giving them some tools to help to reduce some of their harm. The goal is to keep people alive and protect their health, to modify some of our punitive laws and policy reforms to enable this medication option or the medical chronic disease state model to be implemented rather than the punitive nature that we currently see with some of our drugs. Reduce the risks and promote safer use practices for those patients that want to continue to use. We can also help to promote harm reduction strategies in those lives. And then always including persons with lived experience in any service that we're providing or creating, because we want to make sure that these harm reduction strategies can be received by the community that we're trying to serve. And in doing so, language matters. It is important, and you guys have a powerful tool when discussing substance use disorders with your patient population. You can use these words to inform, to clarify, support them, unify, and you can also use these words to stigmatize the situation, to discourage them, to misinform, to shame or embarrass the individual. And I wanted to highlight one of these important studies that was looking at how language can matter. And specifically, the study that's referenced here was looking at a survey that was conducted among 314 healthcare professionals. Remember, these are healthcare professionals. And it presented two different patient case scenarios. One was labeled as a substance abuser, and the other was labeled as having a substance use disorder. And when looking at the data from this survey, we find that patients that are labeled as a substance abuser by these healthcare professionals reporting, they are less likely to benefit from treatment. It is more punitive in nature, that it's the responsibility of the individual for their behaviors, and that it comes with a moral or social issue rather than a medical condition. Enlightening for me was that only 30% of the healthcare professionals would recommend or refer that substance abuser to treatment, whereas 70% would refer the person with a substance use disorder to treatment. So even in our healthcare professional world, we see that stigma and words can make a big impact in our providing of care, not just the individual's access to these cares and services. So here's some other words to avoid. And I know historically I've been a user of some of these stigmatizing languages. One that really stands out to me is we often say substance abuse disorder. And as Dr. Kamyar and I have introduced, we want to make sure that we're using the proper language, patient-centered language, saying substance use disorders instead of an abuser. Another one that you may have heard was medication-assisted treatment. And instead of medication-assisted treatment, we don't use that in any other disease state that we also assist with medication. And so we want to use other words like pharmacotherapy. And when we use that acronym MAT, it should now stand for medications for addiction treatment, not medication-assisted treatment. And so these are just some of the words that we commonly hear in our vernacular that we'd like to suggest that maybe we observe and modify. The last one here, addicted baby. Babies aren't born with any addiction. They don't have the addiction, but they will have dependence on an opioid. And so those would be born with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And these are just some of those terms that you can look at on your own, and I would encourage you to do so. There are some risks associated with substance use disorder, and it specifically can be increased depending on the routes of administration, most significantly with injectable drug use. And we see infectious disease, we see overdose, obviously, we've seen that in our communities, criminal behavior and recidivism, loss of job, breakdown of relationships, and home insecurity. Some of the harm reduction strategies that we have available within our community are specifically targeting some of these risks associated with substance use disorder. Specifically, needle exchange, safe sex education and materials, frequent and available testing for HIV, Hep C, and referral into treatment with warm handoff ideally. We can talk about safer use practices, and naloxone distribution has been significantly increased in Nevada. We have drug testing opportunities, and we'll talk briefly about fentanyl test strips that are now available in our community. Drug court options, some of our treatment options, whether it be through detox or maintenance treatment, and then housing and vocational services are all ways that we can reduce harm in our patients that are actively using or in recovery. So those who choose to not discontinue use at this time, how can we ensure that they have safer use practices? Well, the number one rule is just never use alone. What we've seen is the overdose death rates have increased or skyrocketed in the recent time frame. And so the number one cause of death is that they're using alone and don't have naloxone on hand. Everything in our drug supply, our illicit drug supply right now in Las Vegas and the Clark County area has fentanyl within it. And that's a very potent opioid that can be reversed with naloxone. So encouraging our patients that we identify as having a substance use disorder, whatever type of substance it is, to never use alone and always have naloxone on hand. This was also seen significantly in our adolescent population, where the majority of them were using alone when they overdosed and died. Never share supplies makes sense. Have abstinence days. Only buy what you intend to use when you intend to use it. And then also maintaining their sleep, their nutrition, their hydration schedules. And then utilizing these test strips. Fentanyl test strips are now available at the Southern Nevada Health Department, at all of our behavioral health locations, as well as from the Las Vegas Harm Reduction Center, also known as Track B Exchange. So fentanyl test strips allow someone to use, test the residue or the product that they're about to use, as long as there is a powdered form of it, and test for fentanyl so that they can be aware of what they're about to consume. On the right here, you'll see one of our vending machines. This Las Vegas was the first location in the country to access these vending machines, and are now being implemented throughout the country. And we have a number of these throughout our state as well. These are available for access at the Southern Nevada Health District, at the Las Vegas Harm Reduction or Track B Exchange, as well as at the behavioral health group locations of Cheyenne and Desert Inn. In these vending machines, you'll see kits. The one depicted here in the center of your slide is what's called the works. The works is anything that you would need to inject an injectable drug. So we see that there's needles, there's tourniquets, there is sterile water and cotton, as well as a cooking tray, clean cooking tray, Band-Aids, alcohol prep pads, and a sharp container for disposal. All of this can be then returned to disposal at the location where they picked up the works in the beginning, and it allows them to have access to clean supplies, as well as it has safe sex practice kits, personal hygiene kits, pregnancy tests, and wound care kits involved in these or available in these vending machines. Who should we provide some of these harm reduction principles to? And so this is just a list of patients that you may identify that have highest risk for overdose. We should be talking to a lot of people about this, and this should be just a reduce the stigma all around. We should all be talking about this really in our homes and in our community. But people that have had a previous overdose would be highest risk for a return overdose or a repeat overdose. Anyone who's prescribed over 50 morphine milligram equivalents or chronic opioid pain management should have access to naloxone, as well as anyone who's co-prescribed benzodiazepines or is known to use alcohol along with their opioids or benzodiazepines, whether acquired licitly or illicitly. And then anyone who has chronic conditions that can impair their ability to metabolize the opioids, any illicit drug use, post-incarceration or abstinence, or any time that they've been apart from opioid use would increase their risk of overdose if they were to return to use, whether that be any substance, not just opioids, especially right now in our community, and anyone using alone. So how can we implement more naloxone? Naloxone is a life-saving medication. It is a complete antagonist that is a reversal for someone experiencing an opioid overdose. And as Dr. Kamyar mentioned, it would reverse an opioid overdose. This is an image of the Narcan nasal spray that is available for free within our community, and we'll talk through some of the locations where you could pick that up, specifically Southern Nevada Health Department, the behavioral health group locations that I mentioned, the Track B Exchange or Las Vegas Harm Reduction Center, as well as in our Empowered program at Roseman University over in Summerlin. Naloxone is a full antagonist, and it is very short acting, but it has a very high affinity for that mu receptor. So it will reverse the CNS depression at that mu receptor and block any opioids from attaching to those mu receptors. It is very fast acting in that it can act within a couple minutes. Unfortunately, it's also very short acting relative to some of the opioids that may be on board. So we want to make sure that we're re-administering that dose if necessary and watching the patient to ensure that they are able to maintain life instead of going back into an opioid overdose. If you are on any long-acting opioids, as well as if you are on high-dose fentanyl or chronic fentanyl use, or even heroin, you could go back into an opioid overdose within that 90 minutes. There are different formulations available, and the one that we'll talk about most commonly that has just gained FDA approval is this nasal Narcan spray. That has gone over the counter recently with a new FDA approval. That may sound like it's a great thing, but it is going to be a little bit cost prohibitive. And so we still want to be able to access some of the free products that we have available for some of our patients or community members that may need access to this. And so being able to refer patients to the health department or to Empowered program, the Las Vegas Harm Reduction Center, or CBH, Behavioral Health Group, to ensure that they have free access to Narcan. I won't go into great detail, but essentially what happens in an overdose or in a poisoning is that someone has ingested higher doses of opioid agonist than what their body can tolerate. That attaches to the mu receptors in the brain, causes excessive CNS depression, resulting in cessation of breathing. If that breathing is stopped long enough, that would result in death. And so how can we identify this, and what can we do to reverse this? It's important that we look at the signs and symptoms of opioid overdose. Remember that patients that are using other substances may still have fentanyl within that product. And so then you will likely encounter most of the overdoses that we see in Las Vegas are related to an opioid component of what they're using in their substance. Most notably, you're going to notice respiratory changes as your biggest contributor to differentiating an overdose from someone that's really high. In both cases, they're going to appear a little bit unconscious or just really sleepy. But looking at their breathing and paying particular attention to that, they may have irregular breathing or no breathing, or they may even have a gurgling sound present. Anytime that you see that, you can also look at some of their fingertips or their lips to look for any discoloration, showing that they have decreased oxygenation to those areas. In some skin tones, it may appear blue or grayish. And then if the patient is non-responsive to your shakes or calls to assist them, we also want to ensure that you've done a painful stimulus to ensure that they aren't responding. If anything like that is happening, you can suspect an overdose, in which case we've identified the potential overdose. You can call their name if you know it, shake them a little bit, just like we would during BLS. And then having a firm sternal rub, that is putting a fist with your knuckles rubbing on the center sternum of their chest. If they don't respond, that's highly likely to be an overdose. We want to call emergency services right away, 911 immediately, and there's a lot of Good Samaritan laws that protect anyone, even if they are using at the same time, so that they don't have legal ramifications. As long as they don't have a warrant, they are safe to call EMS and not have any legal responsibilities for recovering someone who's in an overdose. So always call 911 immediately. You may need more than the doses of naloxone that you have on hand, and EMS can provide that. Immediately then follow up with administration of naloxone nasal spray into one nostril, roll them into recovery position, and then re-administer into the second nostril as necessary, and just keep alternating until they've responded. Now, if this is not related to an opioid, the overdose will not be reversed by the Narcan or naloxone. However, if it is not related to an opioid, it will not harm the individual to be receiving Narcan in high quantities. So just keep using the Narcan or the naloxone nasal spray until the patient is able to respond. If they don't respond, EMS will be there to take over. This is what is available on the packaging of the existing Narcan nasal spray that we have by prescription or by over-the-counter products. The labeling for the over-the-counter product that is now being FDA approved might change a little bit, but this is just as simple as it looks like. Check for a response, give the Narcan, turn them into the resting position, and make sure that you've called 911. Re-administer when necessary to ensure that the patient is waking up and responding. After you've administered the Narcan and they're able to regain consciousness, never leave them alone. This is important because we know that they can return back to an opioid overdose, and we want to eliminate that from happening by having other Narcan or an additional Narcan administration if necessary. We want to stay with them until that EMS arrives and just comfort that individual. Let them know that you're with them, let them know your name, that they have overdosed, and that EMS or 911 has been called. Anytime that you administer Narcan to someone who has overdosed, they will immediately enter into withdrawal. And so this is a very unpleasant experience for the individual. They're going to feel extremely physically ill or violent potentially. And so you want to keep your distance just a little bit, but always comfort them. They may wake up agitated or upset in very rare situations, most notably in our oldest adult population. Some of them have experienced seizures, extremely rare, but something to take note of. And then letting them know, comforting them, letting them know that you're there to help them. Here's a list of some of our Southern Nevada community resources that are available. I've mentioned a few of these as we talked through the conversation today, please Google these resources, look at what services are available. This is where we're going to implement the SBIRT and then refer them into treatment. And so these are some of those treatment options or harm reduction options that we might be referring them to. And so being able to familiarize yourself with what network options there are available for us to help with our patients that we're caring for, as well as the families and friends of those with substance use disorders. With that, I'd like to thank you for your time and attention today. We look forward to seeing you and getting to discuss some cases with you.